Thank you for staying with us right here on Good Morning Kenya. My name is Vivian Ndegwa, and right now we head straight to our next interview, which we are going to be talking about the launch of the Global AIDS Report. And joining me for this conversation is one Ngithuku Shongwe, and she is the Director, UN AIDS Regional Support Team, Eastern and Southern Africa, and she is joining us via Zoom. Good morning, ma'am.
Good morning, Vivian.
It's a pleasure to have you on the show today. If we may just get straight into it, just give us an overview of what the report is all about.
The Global AIDS Update is a report that is telling us that as we move towards the end of AIDS as a public health threat by 2030, what leaders do this year, the decisions that they take in terms of resourcing the AIDS epidemic, in terms of sharing technologies for prevention and treatment, in terms of ensuring that they protect the human rights of all those who are vulnerable, will determine whether we succeed in ending AIDS or not.
All right. And all right, what maybe are the key findings, of the report?
Well, the key findings of the report are that we have made tremendous progress in reducing AIDS infections, particularly in countries in sub-Saharan Africa. We have succeeded in putting many, many more people on treatment. 9 years ago, only 47% of people living with HIV were able to access antiretroviral treatment across the world. Today, that number is 77%. In our region in East and Southern Africa, that number is 84%. As you know, for a country like Kenya, Kenya is now one of the top 6-7 countries in the world who ensure that the over 1 million Kenyans who live with HIV have are on treatment. So it's over 95% of Kenyans who are on treatment are on treatment. So the report is saying we have made tremendous progress, at least on treatment targets. We've also made tremendous progress on prevention of HIV in sub-Saharan Africa. We've seen a decline of about 57% across our region. But what the report is also saying is that globally, in other regions, in Eastern Europe, in Central Asia, in the Middle East, North Africa, Latin America, we are seeing a worrying trend. There is a slowing down of the reduction of new infections, and in fact, there is a rise in particular population groups, in particular parts of these regions. We're seeing an increase in new infections. So, it's a mixed bag. In some areas, we're seeing some progress, but in others, we're seeing a decline in terms of that progress. And so the target of ending it as a public health threat by 2030 is threatened, and we have to make some very difficult decisions this year so that we make sure that these actions yield the results that we want.
All right, okay. So as she's mentioned, we are seeing, things are getting better in terms of new infections. According to the findings, as she's mentioned to us, Kenya is doing pretty well, and we hope that we will get to a point where we get to end the new infections completely by the targeted year, which is the year 2030. Now, there's the U equals U, which is undetectable issue, and I would love for her to just elaborate to us what the U equals U is all about and its benefits so far. Okay. It seems we're having a problem with our connection, but we'll get back to her. And just from the findings, it shows that the age group of females between the ages of 15 to 24 and the ages of 25 to 49 are the most have the most newest infections, or rather they have the highest percentage of the most newest infections. And we'll also get to hear from her what may be leading to that finding. And Yeah, we are okay now. So back to you, Madam Anne. If you may kindly elaborate to us the U equals U, what it's all about and what its benefits are.
Small disconnection. So let me just start by answering the U equals U question, and I'll come back to the issue about girls and women. On the U equals U, what that means is that if everybody is on treatment, and in the case of Kenya, I think Kenya has about 1.4 million people living with HIV, and over 95% of Kenyans who are living with HIV are on treatment. But being on treatment means that you stay on treatment, you're adhering to the treatment, and when you do that, your viral load is undetectable. When it's undetectable, it is untransmissible. So U equals U means undetectable equals untransmissible. And so the opportunity for new infections from somebody living with HIV who's on treatment is marginal. It's much reduced. And this is where we want to be. So we want to push and make sure that people get on treatment, but they also stay on treatment long term. And we have many Kenyans who've been living with HIV healthily for over 30 years. But I think what is important, and you raised this point, is that we still have particular population groups where there is high vulnerability to new infections. Children are lagging behind. So children are not as well treatment as adults are. So while our children are, our adults have 95% of treatment, children are below 80%. And so there is a big push now to try to find children, make sure they get onto treatment. But there is a link here with the issue of girls and young women. We are finding that new infections amongst babies are coming from about a quarter of them are coming from teen pregnant. Age. And when they get infected with HIV, by the time they go to the clinics, it's too late because oftentimes they don't even know that they're pregnant because they're too young. And Kenya has launched an incredible campaign called the Triple Threat. This is focusing on the fact that these girls who are infected, we're talking about 15 to 24, where we have the largest numbers of new infections. These girls are experiencing high levels of gender-based violence, sexual violence in this instance, in many cases, unprotected sex that results in underage pregnancy, very often through defilement, at very young ages, 10, 11, 12, 13, 14-year-olds, very high infections and teenage pregnancy at that age, and that results in HIV. Yeah. And so there has to be a big focus, and this is because of the same social norms that we see in different communities. We even have data that show county by county where this is more pronounced than other counties, just because there are particular behaviors that persist in those particular regions. And so we have to have a targeted approach that finds the girls and really focuses on preventing HIV amongst those girls, but also prevent gender-based violence. This is not okay. Making sure that early child marriage is removed from our society. So these social norms must be challenged. And so this is why we see such persistence. We also know that where there are high levels of poverty, including girls who are trying to go to school, to go to university and so on, transactional sex is major. So they're transacting their bodies in exchange for money. And there are many willing men who are willing to pay for this. And unfortunately, they then don't have the power to protect themselves from these infections. So we have a big focus on education. When girls stay in school, we have a higher chance of preventing HIV. We need them to stay in school to the end of secondary school. And then we're reducing their chances of HIV infection and teenage pregnancy. So those are among the big issues that we're concerned about. And in our region, we're seeing 2,400 new infections amongst girls every single week, Vivian, every single week.
That definitely needs to be worked on. We need to find more ways of trying to curb that. As you've mentioned, keeping girls in school would be one of the ways to just try and curb that, so that we reduce the number of the new infections amongst that age group, which is the age group of 15 to 24. Now, there's when it comes to the newborns, you know, what measures maybe are being taken to ensure that we limit the number of, or rather just eradicate it completely, the number of infections in newborns, specifically the transmission of mother to child?
There is a global initiative that we have launched. We call it the Global Alliance for Ending Pediatric AIDS. This is work that we do in partnership with UNAIDS, World Health Organization, and UNICEF from the UN side. But we also have partners in country. We're working, of course, it's led by the government. In the case of Kenya, this is led by the Ministry of Health with Dr. Rose Wafula and the NSDCC, who are leading this incredible work of trying to make sure that they find the girls. A year ago, Kenya launched a rapid results program to find children who are missing, and found over 8,000 children and really made sure that they put them on treatment. So there is a big drive to find the missing children. And one of the ways to do this is through mothers. So, you've got organizations of women living with HIV in Kenya and in the region who are working hand in hand with the Ministry of Health to go into communities and find girls and find young women. When they see young women who are pregnant, they make sure they take them to the clinic so that they get their HIV test, so that they get onto the program to make sure that if they have HIV, they're put on antiretroviral therapy, that they're trained and they're able to prevent, particularly during breastfeeding. In fact, a lot of the transmission is happening during breastfeeding, post-delivery. And so they work with them as peer supporters who work with the young girls to make sure that they're tested positive for HIV. Mm-hmm. So there are initiatives, and there's a whole action plan to end transmission of HIV to newborn children. We call it the Global Alliance for Ending Pediatric AIDS, and Kenya is. Mm-hmm. And so we are hopeful that this will be one of those strong examples from Kenya of eliminating the transmission of HIV to children.
Right. Maybe what approaches are being taken or used to ensure that treatment gets to everybody who is, infected with the virus?
Well, I think the important thing is that testing had become quite routine, particularly in antenatal clinics. So that way we would know where the transmissions were happening. That's not happening as much now, but there is much more targeting because we know better which populations are most at risk. Mm-hmm. And so there are programs to target communities at risk. And to try to make sure that everybody's on treatment. Of course, there's a lot of education happening in the clinics. There are lots of centers where, that are being integrated into health services across the country, both in primary healthcare and in tertiary healthcare. So there is availability of resources and services everywhere. But we are targeting populations particularly. And so what we are seeing is that girls and women, of course, that we've talked about them already, children we've talked about already. But there are communities and populations that are at risk. These populations are what we call key populations. Sex workers are a community that are important because, of course, they have high vulnerability to transmission. Mm-hmm. And so making sure that they have access to health services is really important. And Kenya has done a wonderful job of making sure that there are drop-in centers, there are health centers that are available for female sex workers to be able to access these services and have condoms and what they need to prevent themselves and get on treatment. Mm-hmm. But there's also men having sex with men, gay men. It's obviously an issue. We know it's a controversial issue, but the truth of it is this are a community that are highly at risk. in our countries. Another community, of course, are people who inject drugs. Again, another very vulnerable community, and one that we sometimes wish away. But the truth is that these, as long as anybody is prevented from accessing service, anybody is unable to prevent HIV and get on treatment, then the probability of more transmission in society persists. And so we have to be able to make sure that every single citizen, no matter what community they are a member of, whatever behaviors they are that we may judge or not judge, everybody has the right to access services. And we say that human rights for everyone is equal to health for everyone. And so this is part of the strategies that we are running to ensure that we cover everybody in this AIDS response.
All right, there is the UN 90-90-90 target on treatment, prevention and suppression of the viral load. Could you kindly just elaborate more on that?
We've actually shifted that target now to 95-95-95.
Okay.
These are targets that were set by the global community. And the intention is that if we want to reach the end of AIDS by 2030, then we have to be able to get as many countries as possible on board to reach this 95-95 targets by 2025. In this year's global update, you will see that countries that have achieved this include Kenya. So in Kenya, those who are living with HIV, and Kenya has, I think it's about 1.4 million people living with HIV, Kenya has achieved those targets. So 95% of those people who have tested for HIV are on treatment, and 95% of those have viral load suppression. So we are congratulating Kenya. Kenya is joined by Tanzania, Rwanda, Botswana, Eswatini, Zimbabwe. These are the countries that are the front runners on the 95-95 testing, treatment, and viral suppression targets that we set globally and collectively. And Kenya is doing a great job there.
All right. Okay. What are some of the key challenges facing, some of the countries in the region in ensuring or scaling up treatment of HIV and AIDS?
Well, actually, what this report has, we have three big messages in this report. And the three messages are that the first big message is that we have to resource the AIDS response effectively. We are at a time when there's polycrisis. There are global challenges that are affecting our donor partners. A lot of the AIDS response is funded through the US government. It's funded through the Global Fund to end AIDS, TB, and malaria. These are development partners from the global north. We are finding that the resources are more and more constrained from our global development partners. And what that means is that we have to turn more attention to domestic resources to be able to fund this treatment. But one of the challenges that is very clear is that the debt crisis in many of our countries is strangling the ability for countries to fund the response. So countries like Kenya are experiencing, over 60% of our resources has to go into debt repayments. And so there is less resources available for that. So this is one of the big challenges. We do have a major opportunity that I want to talk about in terms of treatment and prevention. We are seeing long-acting treatment innovations in science that are coming on board. Right now, there is a new prevention treatment, lenacapavir, that you just need 2 injections a year, just twice a year, and you're able to prevent HIV transmission. The problem we have right now is that the drug costs $40,000. We need it to come down to about $40 per year so that we can get everybody who needs that prevention method to access it. So right now, it's only the global north who can access it, and very few in our countries are able to access it. So the challenge is just the cost is prohibitive. And there's a big push right now to move from 40,000 to 40. dollars per year per person on prevention. So this is a very important breakthrough in the prevention agenda. And though the cost may be heavy upfront, what it does is that it reduces the cost, the need for treatment in the future. And for those, then, it reduces the cost to the fiscus for Kenya and for other countries in our region. So that's something that we really are looking to push for. So the debate right now is, how do we bring these new prevention strategies to Africa, to our region, to Kenya, so that we have equal access like everyone else. It's the same as we had in COVID when vaccines were delayed in the global north. And so there is a big push to bring these cheaper treatments and prevention tools to our continent. So that's the second message. The third one is the one about human rights, about inequalities. We have to focus on the fact that girls and young women are very vulnerable. These are the persistent gender inequalities that have been in Kenya and across the region for decades, but ones that show up in HIV. HIV is like a proxy indicator that tells us that gender inequality persists. We have to be able to deal with the gender violence issues, to make sure that girls can be safe in school, that in their homes, that the violations and defilements that are happening for girls at a very young age have to be curbed, have to be focused, have to be invested in. This is not a choice. The triple threat that has been launched and it was launched in Homa Bay recently, and there are programs that are happening across counties. This has to be resourced and invested in a big way. The human rights pushback against gay men and men who are having sex with men, with injecting drug users, with female sex workers. These are communities populations that are vulnerable to HIV. We have to be able to ensure that everybody has access to health. And so this is really our big messages, these three messages: resource the HIV response, ensure that everybody has access to the treatment and prevention tools, and the inequalities and the discrimination, the human rights that prevent access for everyone, everywhere.
All right, and as we come to a close of the conversation, my last question is on discrimination. You know that people living with HIV and AIDS most of the times, or for the longest time, have been discriminated. So what is the report on discrimination this far?
The report is telling us that stigma and discrimination persist. In those countries that we talked about early on in Eastern Europe and in the Middle East and North Africa, these are countries where the populations most at risk are sex workers, gay men, are injecting drug users, and they're discriminated against in the countries where they live. They don't have the right and access to health services. We see the same for some of our populations in our countries, including in Kenya. Fortunately, in Kenya, everybody has access to HIV, the treatment. But we do see stigma and discrimination. Sometimes it's health workers themselves. So even if the Constitution provides the right to access, then sometimes health workers will decide that, maybe you're too young to access this service, or maybe I don't like the idea that you're a gay man, or I don't like the idea that you're a sex worker. And so there is then stigma and discrimination that prevents access to health services. And this is what we're saying in the report, that if we're going to end AIDS as a public health threat by 2030, we have to be able to make sure that everybody has the right to access health services, no matter who they are or where they are. The right to health will ensure that we're able to end AIDS. And that stigma and discrimination, there is work to do to end zero discrimination. There are campaigns and advocacy for this. Every year we have a campaign in February. This is something that we must continue to do and make sure that we retrain and train and retrain health workers, but also our communities, and that peer supporters continue to work in communities to make sure that we do not discriminate against our brothers and sisters who live amongst us, and make sure that everybody has access to health.
All right. Thank you so much, Anne Githuku, for joining us for this particular conversation. We really appreciate your presence.
Thank you.
All right, so that
you.
was Anne Githuku Shongwe joining us live from South Africa, just giving us insights on the Global AIDS Report, which has just been launched. And this is where we end this particular conversation, but Good Morning Kenya continues right now as I hand it over to Mike Migwe. Mike, over to you.
Oh, thank you.